I chose a case study of the 3-day-old neonatal with hypothermia, respiratory distress, lethargy, and poor feeding, written by Monica Joseph and Joseph Hadgeman in the Journal of Perinatology in 2002. Within this case study, a neonatal transport team was called when a 3-day-old infant became jittery and hypothermic after he had stopped being nursed. He was born at 37 weeks to a 34-year-old mother of two. She had blood type B positive. She was tested for many tests such as human immunodeficiency virus and blood tests for syphilis, and they both came back negative. She had a pretty normal pregnancy with no complications. After ending nursing on day 3, he was supposed to be released to go home until his father complained of noisy breathing and grunting and notified neonatology. After the examination of the baby, they found that he had jitteriness in all 4 limbs and hypertonia. He had lost 270 grams only since birth. His blood pH at the time was 7.41. His blood pressure was elevated. He had a high white blood cell count and a very high platelet count. Upon observation of the following symptoms, the infant was started on 10% dextrose with electrolyte solution and given a bolus of 10 milliliters per kilogram, 5% albumin because of his lack of urine. He was also given ampicillin and gentamicin. After he arrived at the neonatal intensive care unit, his pH had dropped from 7.41 to 7.17. He was placed on a ventilator, and his high plasma ammonia level directed a diagnosis of severe pulmonary hemorrhage. Hyperammonemia is often caused by metabolic disturbance. Disorders and problems within the urea cycle enzymes lead to ammonia and all the problems that surface around that. Hyperventilation is another problem caused by hyperammonemia, which can cause respiratory alkalosis, an early warning sign of urea cycle disorder. Physicians should highly consider adding a plasma ammonia level to the initial blood work because if the issue gets worse, the infant could go into a coma and have to be put on a ventilator. This could also cause circulatory collapse and cerebral edema. Lab testing should be conducted after hypoammonemia is established to determine the details. Blood should be taken properly, ensuring the patient hasn't eaten for 6 hours, and ammonia-free heparin and chilled heparinized vacuum are used, and avoid letting the blood sit after they're separated. Hyperammonemia should be treated with urgency because the longer the patient remains in a coma, the worse the prognosis will be. Before transfer to a care center, a tube should be inserted to help ventilation and prevent hypoxemia. An umbilical, arterial, or umbilical venous cord should be inserted to help with fluids, acidosis, and support blood pressure. Then exogenous proteins are removed through hemodialysis, followed by ammonia scavenging therapy. As said on page 3 of the document, patients should be given arginine, sodium benzoate, and sodium phenylacetate in 25 to 35 milligrams per kilogram in 10% dextrose solution, given within a 90-minute period to help treat emergency situations of hyperammonemia. To prevent protein catabolism and further damage, parenteral nutrition is a necessity. To maximize calories and weight, the baby should be given glucose and intravenous fat emulsion, not including protein. Once ammonia levels in the patient are stable, feeding tubes are used using a protein-free powder. Protein shouldn't be cut out altogether, though, because it is essential for life. Without it, the body goes into negative nitrogen balance, which causes the need for more nitrogen to be excreted and worsens hyperammonemia. Ammonia levels should be checked whenever a patient has a urea cycle issue, especially if their symptoms include emesis, lethargy, agitation, disorientation, or emotional lability. If ammonia levels happen to be 3 times or above the normal level, the situation should be treated with urgency and the child should be hospitalized and treated immediately. The only possible way that works as of right now to cure enzyme deficiency is a liver transplant. Survival of neurologic sequelae depends on the length of the time the person was in the hyperammonemia coma. Survivors of this disease usually suffer from mental retardation, seizures, cortical atrophy, and spastic quadriparesis. Many patients that suffer with urea cycle issues rarely make it into adulthood. The key to diminishing neurologic sequelae, along with hyperammonemia and urea cycle defects, is early diagnosis and management to catch the issue earlier and attack it at hand. When a patient presents any of the above signs, an immediate plasma ammonia level should be added to the diagnostic test.